Hi, smart moms and dads. Welcome to another episode of the Brainy Moms Podcast, brought to you today by Learning RX Cognitive Skills Training Centers. I'm your host, Dr. Amy Moore. I am here with my co-host, Sandy Zamalis. And Sandy and I are super excited to welcome our guest, Dr. Steve Hodges. Dr. Steve Hodges is a professor of pediatric urology at Wake Forest University School of Medicine. He's a leading authority on childhood toileting issues. He is dedicated to debunking common myths surrounding bedtime and daytime wetting and poop accidents, emphasizing that these issues are never a child's fault. Dr. Hodges resides in Winston-Salem, North Carolina with his family and has authored 8 books for both parents and children, such as the Mop Anthology and Bedwetting and Accidents Aren't Your Fault. He is here today to share valuable insights from those books, through his blog, and from his brain. Welcome, Dr. Hodges.
Thank you guys so much for having me. Appreciate it.
Yeah, absolutely. We are tickled to have you on the show. As we were prepping for this episode, we thoroughly enjoyed looking through your books and reading through everything. So we always like to start with having our guest kind of tell us how they got interested in this specific topic area, and to share a little bit about how and why you got interested in studying childhood toileting issues specifically, including why you wrote books on this topic.
Yeah, it's a interesting story. We joke. I don't think anyone grows up wanting to be a urologist. You know, it's not one of those. It's not like a fireman or a pilot. So I didn't even know much about urology till I got into medical school. I had no reason to really. And I only did urology as an elective because one of my mentors was a member of our church, and I knew him. I was like, oh, I know he's a great guy, and he was, and I wanted to work with him, and it really opened my eyes to the great field of urology. And then within urology, I decided to do kids just because I was drawn to it. My personality, kind of the patient population, and so forth, was a lot of fun. And so I did, a full urology training for adult NPs, and then did a fellowship in San Diego for just children. And I came back to work, and most urologists, honestly, don't see what you call the bedwetters or the daytime wetters because it's not a surgical problem. Most of our time is spent doing surgery. That's what I was doing today. And so nurse practitioners or PAs or other physician extenders will see those patients. And there's been this kind of established cookbook of how to treat those problems. My practice, as it turns out, we didn't have those physician extenders, so we were seeing them all. And it was actually a blessing in disguise because when I started doing it, I started doing the traditional cookbook therapy and seeing them back, and they were not getting better. It was really interesting to me. And I think this is probably the case in a lot of professions. There's almost a little bit of people, the emperor has no clothes, or people just go along with something that other people do because everyone says it works. And so people were doing this stuff, and I'm like, am I the only one seeing that this stuff's not working? And so I was really racking my brain at what I was doing wrong. And a couple things happened all at once that really affected me. One is that I had a child that needed surgery for a related problem, meaning related to constipation. And I had already had her on laxatives. And when I started the surgery, when we got inside to work on her bladder was really affected by the massive poop in her rectum. Like, there was so much poop in her that it was making the surgery hard. And I was like, this is not so much poops in this kid's bladder. I knew I had her on laxative. So when I finished the surgery, I had to ask the parents, and they said, no, she's been on Miralax for like a year. She poops every day. And I was like, that is so weird. And these were with it folks. They were really in tune parents. So I knew they were on top of it. And then the next week, as fate would have it, I remember because I was sick. I'm sick this week too. It was probably a similar time of year. And I went to Cincinnati for a course on anorectal anomalies that an expert, Dr. Pena, was giving, and Dr. Levitt. And at that course, they were talking about constipation, unrelated to the case I just told you, but for the patients they see and how they use X-rays to diagnose constipation. So I said, you know what I'm going to do? I'm going to start getting X-rays because this is, made me think about the kid I just operated on. So I remember the first kid I saw back, it's like, you're having accents? Yes. Are you pooping okay? Yes. let's get an x-ray. Get the x-ray, and the kid's just full of poop. I mean, everywhere, like not even a little bit. And so I started treating the x-rays more than the symptoms of pooping, and way better results. It was unbelievable. So much so that I thought like this is, I'm gonna get a Nobel Prize. This is crazy. I just cured bedwetting. And so so I told my resident, we gotta write this up. This is unbelievable. And she started looking at it, and she found a bunch of papers written on the same exact topic in the 1980s by a nephrologist in Canada. And I was like, this is nuts. How does I trained, I read the guy's name, but no one ever put it the way he put it in those papers, and the way now I understood it as a problem. It kind of got, I think the terminology for constipation makes it confusing because it means different things to different people. And so I found him. I looked him up. He was living in Arizona. I called him up, and he's like, yeah, no one's doing it right. I can't, I kind of written it off. I'm like, this is insane. We should write this up. And so we started treating constipation aggressively. He actually had, a brilliant guy. He's still in Arizona. His name is like Sean O'Regan. He was a nephrologist. He cured his son's bedwetting. I don't want to go on too long, but it's a really interesting story. So his son was wearing the bed. Nephrologists, they deal with kidney disease. They don't deal with bedwetting at all. But he tried to figure out, okay, why is my son wetting the bed? He went and investigated all this stuff on his own and came to the same conclusion I did, but just 30 years earlier or whatever. And so he goes, well, it's the poop. He didn't use an x-ray though. He goes, I'm going to check my son's rectum. I bet you it's stretched out, because he knew stretching of the rectum affected the bladder. He did this test called an anal rectal manometry on his own son. You put a tube up the butt and blow up a balloon and see if they feel it. This kid didn't feel the balloon until it was really big. And then he had this brilliant notion. He goes, I'm just going to give him enemas every day, and I bet you he'll stop wetting the bed. And he did it, and he stopped wetting the bed. And then he kind of applied that to bedwetting, day wetting, UTIs, and that's kind of what I picked up and ran with. And you mentioned our first book is called one of our books called the MOP anthology. MOP stands for Modified O'Regan Protocol, named after Dr. O'Regan, because we just took his protocol and kind of tweaked it a bit. It's a long story, but that's kind of like the past 20 years in a nutshell.
Yeah, it's fascinating. And I think super exciting when you can find something in the literature from decades prior, right, that somehow did not catch on, but's brilliant.
Yeah.
And I mean, we could talk about that with diabetes and blood sugar, right? Like, and so I love that you found that and ran with it. And so let's talk about some stuff related to that. Okay. So you talk about, you actually open your new book that by saying that bedwetting and accidents are never a child's fault. And they aren't a normal part of childhood.
Correct.
Right. So let's hear more about why they aren't normal.
So I don't know how, if you want to look at it, like, I think God designed people, or evolution evolved people to wet while they're sleeping, right? So it's a reflex. It's not normal. And I don't know, maybe some sick animals do it. I'm not studied up to date in all animal literature, but I think it's pretty rare in the animal kingdom in general to wet the bed. And so I know it's pathological. And so and the kids do definitely have behavior that sets up the bedwetting, but it's not like anything unique. So what I think, my model in my head is like, humans are too smart for their own good, right? So we're at this huge brain and we overthink everything. I don't know if you guys have kids, but like, what are the 3 hardest things for kids? This 3 simplest things in the world: eating, sleeping, and going to the bathroom, right? It's just like the things that should be like just every other animal does without even thinking about it. And since we overthink it, like, what are we going to eat? I only want to eat, plain pasta or whatever. Or I don't want to sleep because I'm not tired. Everything is overdone and messes up. And so toileting is the same way, is where, peeing is easy to do. It's not really uncomfortable, but pooping is pretty uncomfortable, whether it's too hard or too soft. And so very early on, kids develop this kind of holding behavior, and you see it in newborns. It may phase out, but it's probably the most common medical condition in kids in terms of fecal retention from discomfort while pooping. And you probably all seen it when they change diet, they get antibiotics maybe, or they start dairy, they get backed up and they start holding. But I would say all kids hold to some degree. A subset of those kids are prone to this reflex that leads to bladder overactivity. And it's a little tricky, but basically everyone that gets a dilated rectum because they hold their poop won't get the same response in their body. So it's kind of not fair. It's like when I see kids with kidney stones, they probably drink plenty, as much as their friends, but they need to drink more just because the way they're wired, they need to, the way they're built, they need to drink more. And so those kids that are prone to bedwetting, they may hold the poop not much more than their friends, but because their bladder is more sensitive to it, they start wetting the bed. Because it happens when you're really young, and people tend to outgrow it. People write it off as a normal part of childhood, but it's definitely treatable and preventable. And so, yeah, I think I don't want to imply that if you peed and pooped perfectly, that you would have problems too. So kids do retain poop, but like every kid does. I think some adults do. So that's why it's not really their fault. And a lot of times, unfortunately, they get blamed for the accidents when they don't even know why they're happening. The parents don't even know why they're happening, really.
Right, but it's assumed that it's behavioral. I mean, in fact, that's why my field, why the mental health field ends up with these kids, right?
Yeah, and I don't know on what mountain to shout it out on, as on the highest mountain to shout it out on top of is that it's a major cause of abuse. I'm sure you've seen it too. It's really sad, and I hate it when a simple misunderstanding. Misunderstandings cause all problems mostly in humanity, but this one is, to have a kid that doesn't know any better, doesn't even know why they're wetting, punished because they're wetting, that breaks my heart. So hopefully we can educate parents about that so that doesn't happen.
Yeah, absolutely. I actually watched like a Friday night movie in the late 70s. Remember, it was like Friday night at the movies on NBC or whatever on television. And it had such an impact on me as a child. There was, a character in the movie who wet the bed, and he was probably 9 or 10. And the mom would actually strip the sheet off his bed and hang it from the balcony in the front of the house.
Yeah.
So that as his friends rode by on their bikes after school, they would see this urine stained sheet. It had such an impact on me at, 8, 9, or 10 that I never forgot it. And I actually then remembered it as I was reading your book again. And so it breaks my heart too.
I mean, you can watch. What my pet peeve now, and I, it's funny because certain things appropriately catch on as inappropriate, right? Like you shouldn't say certain words anymore. Like there are words we don't say now that maybe were said when I was a kid, and it's fine. But like every time I turn on the news, I hear somebody say a bedwetting politician as a derogatory term, and it like drives me. I'm like, how is that? Like it's like usually pretty well-meaning, educated people on TV saying that. It's like it's all over the news. I'm like, that is so horrible if you think about calling someone a bedwetter because they worry a lot or something, or I don't know. It's just I don't know why that is allowed yet. We should make a pact to make that stop.
Yeah, let's do it.
I tried to write a blog about it. No one cares. It's really not.
Somebody
I get
will
it,
find it, 30 years from now, right?
I know, yeah.
Get back out and go, this guy was a genius.
Yeah, exactly. But yeah, so we don't want these kids to feel bad about it. It's already embarrassing enough, and I like them to know that you can treat it and make it better, and it's not their fault.
So Dr. Hodges, it's, you're basically saying is that most bedwetting or accidents is caused by chronic constipation, but it's not always obvious to us as parents or even to the person who's having the accidents that it's a constipation issue. Like you had told us about the surgery that kind of kicked you off on this thing.
That even pooping every day.
Yeah, even pooping every day
doesn't mean you're not constipated.
Right.
I think the problem is constipation is probably not the right term, but it's a term that people get. They understand like constipation makes sense, like you're backed up, but it also implies other things that don't jive with what we're talking about. And so, in that first call with Dr. Regan, I said, these kids aren't constipated; it's the rectum's dilated, and he said, exactly right. I remember his voice because he's got an Irish accent. It's incomplete emptying of the rectum, and that's the best way to put it. And so if you hold your poop, when the poop gets to the rectum and you feel it and you go poop right then, like nature intended, you don't have problems. But if you wait, which I don't think the human body was ever designed to do, like to sit there and wait, for days or whatever, Then when you do go later, you won't get it all out because you overstretched it, and then you kind of reset the sensation of fullness to a larger volume. So you turn the rectum from a sensing organ, an emptying organ, to a storage organ, and that's the problem. And so I've struggled with this, for 20 years now, like what to call it, because incomplete emptying of the rectum sounds weird. No one gets that either. Rectal dilation sounds weird. So we try to say constipation with a caveat. But you're very right. You can have, most of the kids I see have no symptoms of bowel dysfunction at all. And it's even more interesting. When I first figured this out, I was like, great, I'll just send this to these kids at GI, and then they'll fix them and they'll be fine. And the GI sent them all back saying they're fine with no treatment. They even did like SITS markers test. If you give these kids SITS markers, the things that go, like little things that show up on an X-ray that go through the colon, they go through normally, the transit time. So it's not like it's the road is moving through. It's just you've made a huge road. So instead of a 1-lane highway, you've got like a 6-lane highway now, and that's the issue. So you gotta shrink it back down.
Yeah, so you talk about in your children's book, you kind of use the analogy of a balloon, right? And so that when you're not fully emptying your rectum, then that's putting pressure on the balloon that has the balloon always has a hole in it, right? And so then that pressure causes urine to leak out.
So the kind of real estate model is a good one for diagramming it because it makes sense to people. And I think probably most women that have been pregnant have had some urinary frequency just because their bladder's pushed on. But the real reason is more neurologic. It's just a little bit more complicated. So the nerves that go from the bladder to the spinal cord to tell you you're full. So these nerves, like in the wall of the bladder, as they stretch, the bladder stretches, it stretches the nerves and it sends a signal. And it's almost like, think of it like remember there's like kind of like metal detectors that beep that you get closer to metal or whatever, they start beeping more. So that beeping might get faster as the bladder gets more full. But the problem is if you, at some level, it will set a reflex off to make you pee whether you want to or not. And the rectum is right between the bladder and the spinal cord. And so it stretches those nerves as well when it stretches out. And the body doesn't know the difference because it just knows the signal's coming through. So you have this heightened state of fullness of the bladder, even though it's not full. The body thinks it's ready to go. So it's a little bit of urine adds to it, and it just fires off a reflex. And so the analogy is a lot more like instead of leaking through a hole, kind of like if they hit your knee with a reflex hammer and your knee kicks, there's no stopping it, right? And you don't have any control of that. Your bladder is going to squeeze the same way. It's just going to autopilot and empty. And so that's why when these kids wet the bed, they don't wake up. And that's why when they have accidents while awake, a lot of times they don't even know they wet. It's very interesting. Like I've had kids pee on themselves in my clinic in front of me. And I said, you just peed. And they said, oh, did I? And it freaked me out so much at the beginning. I was like, do you have like nerve damage? Like, because I did like pinprick tests on this one kid to see if he could feel everything because it freaks you out. But now I know it's just part of the disease process, or not disease, but you know what I mean, the condition.
Right. How common is this?
A quarter of kids at 5 years of age have incontinence of some kind, mostly bedwetting, but so very common.
Yeah.
And, I struggle sometimes with how big a deal is it if like a 4-year-old wets the bed? Is it that big a deal? Like because the treatment's not easy either. I think kids should be on a regular bowel regimen. They should be pooping fine. I take one of my daughters was wetting the bed when she was young, and I just gave her a little bit of Miralax and got her emptied out, and she was fine. And so I do think if people jumped on her early, kids would be cured a little bit more easily. But if you have a child that you've done some simple bowel routine and they're still wetting the bed, you have to make a decision, do we want to go all in or do we want to wait a little bit? Because the caveat of our treatment is that some kids do get better on their own. You just don't know when they're going to get better. About 15% get better a year at the age of 5. So, your child could be wetting the bed at 5 and then be dry at 6, or they could still be wetting at 16. You never know how it's going to settle out.
Right. And I think you mentioned it's a pretty high percentage of kids, untreated 9-year-olds who are still having accidents at 18.
Yeah. I think if your kids, I'm pretty aggressive. I think 4 years of age, or so. But if they're starting school and still wetting the bed, I would kind of start the treatment. You don't have to be as aggressive as we are in some of the some of the, the enema therapies we use. You can start something oral, but then, if they're not getting dry, you can get an X-ray, see how backed up they are, and then kind of up the ante. Because and that's for two reasons. One is I don't think it's healthy for colon to be that dilated anyway. We have this theory that these kids grow up, if they're untreated, and get IBS because their colon's so dilated they can't, process their bowel normally, their fecal load normally. And the other is we're seeing a lot more evidence that this affects sleep. That people used to think that bedwetting is caused by deep sleep, but in reality, it's a sleep disruptor. And so if you have kids wetting the bed, they're probably not getting restful sleep. And so it's affecting their brain development. You guys know as well as I do how important sleep is for young brains. So that's why I'm like, just jump on it, try and knock it out as fast as you can so they can have a kind of normal brain development. If that makes sense.
All right. So before we talk about what we should be doing, let's bust some myths on why some of the typical strategies aren't the way to go, like limiting liquids.
Yeah. So the main thing that's going to set off the bladder spasm is going to be this kind of rectal dilation we're talking about. But it's obviously multifactorial. Like if you made no urine, you would not wet the bed problem, right? Obviously. And so the amount of urine you make and the speed at which you make it can influence how likely your bladder is to contract. But at what cost? If your child's thirsty and they're dehydrated and they're constipated already, do you want to really limit fluids? And the reality is that, we can all drink whatever we want and then go to bed, and we're fine. So it doesn't really solve the problem. It can be a contributor to getting dry if you're really just trying to get dry nights, but it's not the root cause. It's more of a ancillary kind of feeder into the problem.
What about like learning how to hold it, like having your child stretch their time?
Yeah, that's a good
Yeah,
one. So I think, because, this process, as a kid growing, their bladder does stretch and grow, but forcing the issue is just not helping anybody. And I do feel bad for those kids because, one of the conditions we see is frequency, because the nerves that are coming off the bladder, they're all in the pelvis. And the nerves that make you feel like you need to pee are different from the nerves that make you actually pee, And so we have some conditions where the kids sleep fine at night, but during the day they have to pee like so often. And the parents just hold it, you just went, just hold it, just went. And I just hate the thought of them. All they know is their brain's screaming they have to pee, and someone's telling them don't go pee. I hate that thought. So you can't stretch a muscle forcefully. You got to fix the root cause, which is this neurologic cause.
So then rewards aren't going to fix the underlying neurological cause either, right? Like I think you said overactive bladders do not respond to M&Ms.
Exactly. And they don't respond to logic either, because I see that a lot with like a good example is like getting a kid to poop on the potty, one of the things we deal with, or getting them to go to the bathroom. When you have the normal sensations, you will go to the bathroom the right way. It is amazing. I've seen kids with that their parents say these kids won't go to the toilet, immediately start peeing normally without any other coaching other than fixing their bladder so the sensations come through normally. I often tell parents, what if I told you to go home and not eat until I told you, right? You could say, okay, I'm not going to eat until you tell me. If I didn't call you for a few days, you would be like, I got to eat because your brain is driving you. If I said, go home and don't sleep till I tell you, you would fall asleep. Even if I told a parent, go home and hold your pee until you have an accent, they would not be able to do it because the urge is so strong. And so when you fix the condition in the pelvis, the kids get these normal sensations. When the urge to pee comes on, they go normally. And you don't have to reward them. You don't have to explain it to them. It's like your dog. You let them out and they go pee. You don't have to explain it to them. It comes naturally. And that's what we want to restore, this kind of normal physiology so the body works like it's supposed to.
Is potty training too soon a concern? Like, is there a kind of an ideal time to start the process of potty training?
Yeah, I appreciate you bringing that up because, when I first started, I was really dogmatic about this. You can find some articles back in the day because I'll give you a good example. When we see UTIs in little girls, which is a common occurrence in 3-4-year-old girls, it's right after potty training. It's amazing. It's like they were fine, and they come in. They say my daughter's had 5 UTIs in 5 months, and I'm always like, let me guess, she just started potty training 5 months ago. They go, how'd you know? And so I knew from that fact alone that withholding or holding stuff in happens, is initiated with potty training, part of it, or it gets worse at least. And so I said, look, these kids are getting backed up, and then you have this kid that is 3, and you can tell them maybe, hey, try to go pee, or versus a kid that's 2 or 1. How are you going to have those conversations? So I said, if we have these kids and they're peeing and pooping in the diaper, and they're getting it out of it healthy, why are we forcing to put them in underwear, and then potentially start this withholding, and then get all these problems that then we deal with 5, 6 years down the road? And so I really push for, listen, let's just wait till they're 3.5. You can talk to them about it. They understand what's going on. And even then, what other behaviors do you leave up to a 3.5-year-old? None. So they still need guidance, even after potty training. I hate being dogmatic about it, but because I know people have other concerns. They have schools. They have economic factors of diapers and stuff like that. So I've softened it a bit, saying, look, you can train a kid whenever, as long as they're going to the bathroom regularly and emptying completely. And I do know now that it varies amongst the genetic. There's a genetic variation in that, and so some kids can get backed up and not have problems. So a parent says, I really want to train my kid early, and we have no history of bedwetting in our family or UTIs. I'm like, okay, your genes may be okay. Just make sure they poop. But kids that have history of it, I tell all my kids that when they graduate from my program, when you have kids, we're getting them pooping regularly. We're not training them early because it's a problem. So I think the earlier they train, the more they hold, but holding doesn't necessarily affect all kids the same, if that helps.
So can you estimate what percentage of kids will be successful in training early, like without holding?
Well, yeah, I think, it's a good point. So, but if you look at all comers on the studies they've done, roughly about a third of kids, if they get rectal dilation, get bladder overactivity. So a third of the kids are going to get bedwetting or overactive bladder to varying degrees. A third of kids will get bladder underactivity. So they'll be the ones that right when you train them, you'll be like, oh man, they go all day without peeing. Isn't that weird? And most people don't see a doctor for that. They just kind of comment about it as being a unique party trick or something. And so those kids never see us. Once in a while they do. And a third of the kids don't have any change in bladder function. So we're only seeing about a third of the kids. But, it's not always so easy to predict. I've seen some kids whose parents had no issues. Maybe the way the genes came together just caused this problem. But in general, and even if you didn't get potty accidents from being backed up isn't healthy, I don't think. It changes your microbiome, doesn't make you feel good. So I think we could really promote kind of regular pooping in all kids, hoping that we don't get problems in any of them.
So let's talk about what does work. We talked about what doesn't. What's the healthier way to approach this from a parent perspective and trying to help their child evacuate thoroughly?
Yes, I look at it 2 ways. One is just kind of getting them potty trained or getting them regular before potty training. And then after potty training, if they have accidents, we have we have a book called Pre-Mop, which is setting you up so you're pooping the right way. And that is just when you have a baby, just kind of really be observant. I think there's a lot of info out there from pediatricians, especially if there's a child that's breastfed, that, okay, they can go a week without pooping. It's normal, and I don't want to get in the middle of all that, but I do think you should really watch them like a hawk. And if they're straining to poop, struggling to poop, putting out poop smears instead of regular poops, that you should just really talk to a pediatrician about getting them going more regularly. And you can definitely find a program with your doctor or with changes or all the medications available, or laxative available over the counter to get the kid regular. And if you're setting them up for potty training, definitely don't even try until they have regular mushy bowel movements every day. Some of the signs that people really write off early on are hiding to poop. They think, oh, they just like their privacy. But hiding to poop is highly associated with constipation. And it makes sense if you think about it. Pooping should be what I like to see in these kids is they're playing Legos or whatever, pause, poop, keep playing. That's the ideal kid that's 3 years old and pull-ups are ready to potty train. They're not even thinking about it. It's not even in their head. These kids are I gotta poop. I'm in the corner. Don't look at me. I'm in the closet. My face is red. They're backed up. I can guarantee you, because they're struggling to get it out. Yeah, right. It's so common. And so I have a memory literally behind the couch.
Me too.
Poop. My mom says I regressed. And so it's funny. There's a comedian that has a joke about his first memory as a child is letting out a hard poop. It's like it brought me online. So it's traumatic. So That's my key. So if you have them on the right protocol, whether diet or, people may or may not want to use Miralax or magnesium, you can get them pooping nice mushy poop. Another trick is if they need help, if it's in their brain, they're one of us, an anal retentive, they're gonna hold it no matter what you do for a long time until they know better. So if you get them through, people will often give them a little bit of Miralax or something, get them pooping and say, okay, now they're off the Miralax, they're fixed. And it comes back and like, oh no, what's wrong with my kid? There's nothing. They just don't like pooping hard poop. So you got to keep it soft somehow. And that's kind of prep for it. And then potty training, once they're 3.5 and pooping okay, I just like to put potties out, tell them, this is where we like to do it. And they'll feel it fine and they'll do it. Peer pressure, positive peer pressure takes over. And the only issue we run into sometimes is kids get so comfortable pooping in pull-ups that they don't want to poop in the potty. And so we have to develop a couple of protocols to kind of convince them to do it there. But if you do it that way and you take your time with it, you're much less likely to have a backed up kid that's having accidents for years after the potty trained.
All right, so let's talk a little bit about Miralax and lactulose and magnesium citrate. And so what do you say to parents who say, well, I don't want my kid to get hooked on it, number one. And number two, do you prefer the 2 natural solutions over the Miralax, for parents who are uncomfortable with, the polyethylene glycol.
Yeah, totally.
Chemical.
So I think that modern humans' poop is a lot probably firmer than it should be. I did the fiber intake's way lower than caveman diet, that's for sure, right? And so poop was probably had a lot more bulky fiber in it, and so it was less uncomfortable to poop back 10,000 years ago or whatever. And so getting to that with diet, I just think is almost impossible in modern culture. Like, what are you going to feed them? Like just raw broccoli and nuts and stuff. And so I think that you probably almost, to get to where you need to be for the poop to be soft enough for a kid to not want to hold it in, you're going to need to use something like magnesium or lactulose or Miralax. The reason Miralax became so popular is because it is dissolves in anything, tasteless, and you can dose it so easy. You give a little bit, poops a little soft. You give a little bit more, poops harder. And it does have an unfortunate name because polyethylene glycol implies a lot of stuff. Everything I've seen on it, meaning, and I studied the pharmacokinetics, is that it's completely dissolved, completely removed from the body through the colon and no absorption. And I have no reason to doubt that. But there are people that take it. There's reports. I've had patients that say, well, it affected my child. And obviously, you would not want to take something like that if it affected your kid. And so there are options. Lactulose is a prescription version. Lactulose actually has more side effects than Miralax because it causes a little bloating. And there's not a really good clean out protocol. Like Miralax, if you really want to get a good poop, you can give a ton of it and just clean them out. Lactulose doesn't offer that. And magnesium is a good supplement. But again, magnesium levels are something you probably got to keep an eye on. And it's just harder to give. It has a taste. And the big beef I have with magnesium is that it's very easy to give and very healthy to give as a supplement in low doses. Helps with sleep and migraines, but the actual laxative dose is much higher. And so people sometimes get confused and they'll use like the supplement dose. And I don't care what dose they use if it makes the kid poop better, but sometimes they'll maybe not get the progress they wanted to because they're underdosing magnesium. So I would just play around with all the options. There's plenty out there. There's a lot of reputable pediatric laxative sellers that will sell you some stool softeners and laxatives. But to your point about whether or not you get addicted, all it does is make the poop softer. And so it's not affecting how the colon works, or and actually I would think it makes the colon work a little bit better because kids are less likely to retain it and start stretching things out. Probably making kids poop more like they should than eating just even the regular best diet you can, given limitations on the modern diet.
Okay.
So in extreme cases, you do talk about enemas, which is kind of an aggressive approach, from a parent perspective,
Yeah.
right?
Right. And we were actually talking about
Yeah.
ascent as well with that too. I mean, so I'd love to talk about the aggressiveness of it and why you love it, right? Because obviously it's effective. But then what do you do when your child is kicking and screaming and refusing it?
Yeah.
Like I can remember holding my kid's butt together, using the glycerin suppositories, while they're screaming at me and I'm holding their butt cheeks together. Right. And
it's no fun for anybody, right?
Right.
Yeah. So when I started out, I was doing Miralax only because again, I'm a urologist. I have no training in GI care. So I picked this up as I've learned through the course of my career. But when Dr. Regan, when I first talked to him, he's like, I found his papers. He's like, enemas all the way. And I was like, it's brilliant because the problem is there, right? The problem is in the rectum. It's not up top. It's at the end of the colon. He's going right to where the problem is. And so when I started doing that, my results got way better. So it's like, and it's been like a series of just like trying to find the best way to get a kid empty. And that's, I don't even know the theoretical fastest way. If I could have a magic wand and I emptied the kid's rectum completely, how fast could they get dry from bedwetting? I don't even know. So a lot of times I'll tell the parents, it's not a race. We want to get there, but how fast do you want to get there, and what's best for your family? And definitely the treatment can't be worse than the disease. If the kid minds bedwetting less than they mind enemas, then you could probably take a different approach. The corollary to that is that if your kid has needs a vitamin or something, they don't want to take that either, and you have to give it, or they need an antibiotic. You find a way to give it. So I do like to temporize a little bit people's fear of enemas as it's just take your mind out of it. It's just a treatment for a medical condition. Most kids actually do fine with them, and once they start doing them, they actually ask for them, not in a weird way, just because they know that they're not getting empty. They can feel it. And so I know people tend to write off enemas as kind of never say never go there kind of deal, but I would say keep an open mind, because a lot of the concerns about enemas we put on the children, not the children. But I do have some memories of that. I had one where my daughter, y'all get that point where they can't poop, right, from something so common, especially kids like ours. And so I gave her one, and she's screaming, and then she pooped. She goes, thanks, Daddy. Like such a contrast of like, but she did say thank you, but I don't want to do that again tomorrow. And so, but the kids we treat, they do they see the light, because they start feeling better, and they do ask for them. And I think that that's not a bad thing. I think that they realize their body was not functioning normally, and they want to be back to kind of normal. And so, keep an open eye for the treatments, but we have a million different protocols. And we would never have a parent do something they don't want to do. If they don't want to use Miralax, they don't have to. If they don't want to use enemas, they don't have to. If they don't want to use X-Lax, we just got to find a way. If you came up tomorrow with a new way to get kids empty that was better than what I have, I would start, recommending that one, because just want to get the kids empty and better.
Yeah. All right, we need to take a break. Let Sandy read a word from our sponsor. And when we come back, I just want you to touch on a couple of those other alternative surgical treatments, Botox, InterStim. They're out there, and just love for you to speak to that when we come back.
Perfect.
Being pulled out of class for reading help in 3rd through 6th grade really hurt Joshua's confidence. He regularly referred to himself as dumb or stupid, and he often rushed through work just to get it done. Then his parents enrolled him in Learning RX, an intervention they referred to as a complete game changer. Joshua has not only been thriving academically, but also enjoying learning and even reading for pleasure. His parents are proud to report that Joshua is feeling so much more confident that he even performed in the school musical. While your child may or may not achieve these same results, Learning RX would be happy to work with you to get answers about your child's struggles with learning. Get started at learningrx.com or head to our show notes for links for more helpful resources.
And we're back talking with Dr. Steve Hodges. So just touch briefly a little bit on bladder Botox and InterStim and these other options that parents might be looking at.
Yeah, if you have an older kid, so I'm completely confident that if we shrink the rectum down, the kid will stop having accents. But it's not that easy to do. Easier said than done sometimes. If you have a chronically dilated rectum, it takes a lot of work. And some kids we have are teenagers, they're getting ready to go to college. They need to be dry like now. And so Botox has been great. Botox basically, there's some oral medicines you can take to block the signals that are coming to cause the bladder to squeeze, but they're minimally effective. Botox is much more effective. And at the right dose, it can provide temporary relief from accidents. And I've had great success with it. Some kids I've given to it, and by the time the Botox wears off, they're cured anyway. And so they never wet again. I've got a lot of satisfied customers. And so I think it's definitely something to consider, because it's an option, right? It's expensive. It's a procedure. You're under anesthesia. But there's hope. So these kids can see, okay, if I can try this and this, and then I can get to Botox, and it works really well. And I really like it. Honestly, and this protocol is not for everyone too, right? There's some families, they don't have the economic or mental bandwidth to just do all this, these enemas. And so if you have a nice medical procedure, it can help them. Another one is the InterStim. InterStim is like interesting because it stimulates the same nerves the rectum is stimulating to cause the accents. It just reverses the stimulation. So I when I figured out how InterStim worked, I was like, oh, it's like a superhero rectum. It's the opposite of the rectum. It's coming to do the, or the rectum is like an evil InterStim. Basically, it's making the bad signals. So it's like a little pacemaker. You put it in. I've had only a few kids do it because it's an implantable device, and so it's not for everyone. But it can cure the symptoms immediately, again, because it's overriding these signals. It doesn't fix the actual problem, but it's permanently blocking the signals that are causing the problem. And it lets you take your time. You say, okay, my colon's full. I know what's causing these issues. Let's fix the bladder, and then I'll slowly get empty by doing some kind of oral laxative. And so in 10 years, my colon's rehabilitated, but I haven't been having accents for those 10 years. So these are things that obviously you shouldn't jump to. They're last resort if you've failed medications. But I want families to know that there are options out there. There's no reason to be having accents for years because you can get it treated one way or another.
So do you have any statistics on the correlation between childhood constipation and then later adult health issues like IBS, or do you see that? Or
I don't. It's my kind of like gut feeling, which is not very scientific. It's just I see these kids, right? And I'm like, okay, I'm seeing how many kids? Not that many. I'm just one guy, and they're all full of poop. And there's kids probably 10 miles down the road that don't see me. They're wetting the bed, and the bedwetting goes away. And ties into one of my theories is because this reflex. This is an important point. So when you had a baby, remember they would pee and they wouldn't even know they were peeing, right? Before they were conscious, the little thing would light up on the diaper and they were wet. They didn't know they peed. That's because they peed with this sacral reflex, and that sacral reflex is what persists when kids have accents. Persists because of the rectal dilation, but it's a primitive infant reflex. That reflex will go away eventually. That's why kids stop wetting the bed, with or without resolution of the constipation. So some kids will get better dry at 12 or whatever, but they're still constipated. So then they have this colon that's really dilated, and they're going to have this disrupted stooling pattern because it's hard to maintain regular bowel movements if your colon's like 10 centimeters wide. And so then when I would see adults, and I would see their x-rays of IBS patients, I'd be like, well, wow, these look a lot like the kids I treat. And then when you look at the treatment for IBS, it's basically laxatives. So that's kind of where that theory comes from. I don't want to claim it as fact because it's not, but it definitely jives. And I had a weird aha moment with another interviewer the other day that she was saying, do you think these conditions could be tied into IBS at all? I'm like, were you reading my mind? You've been spying on me? And she's like, no, my son was a bedwetter and he had IBS when he grew up. I was like, yeah, makes sense. So something to keep in mind.
yeah.
It's definitely not healthy to have a hugely dilated full colon.
No, I can't imagine that it is.
Yeah.
You had talked about in your book about there being a high correlation of constipation with children and adults with autism. Can you talk a little bit more about that as well? What does that stem from? How does that connect?
Yeah. So I can't really put a finger on the reason why it happens. I just know it happens, and it kind of one of the things that like it makes sense, right? So you have an autistic kid that have trouble with expressing their emotions or their feelings. They have very sensitive to stimulation in different ways, and so the thing that sets off this withholding, this anal retentiveness, is just amplified in autistic kids. My bottom hurts. I squeeze my bottom, and the pain goes away. So I'm going to do that all the time. So the problem with them as well is that if you see an autistic kid in the clinic and they're not potty trained at 6, doctors may write that off because they're like, well, they're developmentally behind anyway. They're just not ready to be potty trained. When in reality, they may be just so backed up full of poop that they can't be potty trained. And so the withholding is very common in the kids on the spectrum and to a greater degree. I think some of the worst x-rays I've seen on kids have been kids that are autistic. So I would definitely encourage all parents of children with autism to keep a real good close tabs on their children's bowel habits and treat that. And I have a couple things. Yeah, I'm not trying to make crazy snake oil claims, but I have parents. I have a email I got the other day from Australia. She said, like, my kid was constipated, awful. We saw this protocol, we fixed it, and his behavior's improved a lot. And I think it makes sense. I mean, I don't care what kind of behavior you have. If you're uncomfortable all the time, you're not going to be behaving to your optimum ability.
Absolutely. Well, and poop is getting your body, I mean, it's removing the toxins from your body, or the parts that you don't need from what you've ingested anyway. So, I mean, if you keep that in your body, there has to be a little bit of reabsorption happening, right? Or no?
Yeah, I think the main thing that messes you up is that, and they've proven this, is that your microbiome, it changes for the worse if you just hold the poop in there. Like if the poop is flowing through normally, you have a certain microbiome. If you hold it in there, it gets worse. And how that ties into your gut brain and all that stuff is beyond my training, but it's definitely not a good thing.
Well, sure, because like people with slow motility have a greater chance of developing small intestinal bacterial overgrowth, and
Yeah,
right. I mean, it's
it
all
all goes
connected.
up. Yeah, it's
Yeah.
amazing. These kids, they'll have constipation of the colon, and you give them an enema, and they throw up if they're really full. You see that tie in, like it's going all the way up the nerves, or all the way up to the stomach, and causing a reflex, and freak parents out. Like, or if they take a lot of Miralax or something, or magnesium, there's only so much you can hold in there, and they think that maybe the treatment is causing nausea. It's not the treatment; it's that they're so full. It's just hard to get them empty without the body kind of reacting in a negative way.
Yeah. All right. So all of this great information is in your book, right?
Oh yeah, and we do have a website. It's probably the best place to go. It's www.bedwettingandaccidents.com. And that way you can get kind of links to me, to the books, everything you need. Kind of, it's a good home base for all things potty accidents.
Fantastic. Anything that you didn't get to say that you still want to share with our listeners?
I just think don't accept accidents as a normal part of the child's life. There are a small percentage of kids that have real problems. Congenital neurologic or anatomic issues that could be a cause of incontinence. So you see your doctor, make sure they don't have anything serious going on, and if they're worked up and they're otherwise healthy, then the constipation is the cause. You come find us, and we'll get them empty and get them sorted out. But definitely don't ignore it.
Fantastic. All right, Dr. Steve Hodges, thank you so much for being with us today. Listeners, again, his website is bedwettingandaccidents.com. We will put that link in the show notes, along with a link to buy his books. All right, thank you so much for listening today. If you liked our show, we would love it if you would follow us on social media at the Brainy Moms. We'd also love it if you would review us on Apple Podcasts. If you'd rather see our faces, we are on YouTube. And of course, don't forget to check out Sandy on TikTok at the Brain Trainer Lady. So look, that is all the smart stuff we have for you today. So we're going to catch you next time.
Have a great week.